Welcome to the Radiographics Podcast. I'm Wende Gibbs. We have two more great articles to summarize this week. They're both from the archives, but remain essential for all of us, those in practice and those studying for the boards. I had a different article teed up for this week, but on call, I had to evaluate a brachial plexus study for thoracic outlet syndrome. As a neuroradiologist, this isn't something I see too often, so I had to refresh my knowledge, and of course, when looking online, the first thing I see is a great radiographics article come up. This really saved the day. Dr. Frederick will start with a classic comprehensive paper on spinal cord lesions. This one has so much vital information in one paper. I learn more each time I read it.
Diagnostic approach to intrinsic abnormality of spinal cord signal intensity. This article seemed like a good one because in addition to being practical, it has a lot of good boards-relevant material. Myelopathy is a broad term that refers to the clinical symptoms related to spinal cord dysfunction, such as motor and sensory changes and bowel and bladder dysfunction. MRI plays a key role in evaluation of suspected myelopathy because it can help identify a cause and delineate the extent of the abnormality. T2 hyperintense intramedullary signal is a common and important indicator of myelopathy. T2 hyperintensity can reflect many processes at the microscopic level, including edema, blood spinal cord barrier breakdown, ischemia, myelomalacia, or cavitation. The differential diagnosis includes a large number of diseases that affect the spinal cord. As such, abnormality of intramedullary signal intensity is somewhat nonspecific and can present a diagnostic dilemma. Extrinsic compression is a common cause of intramedullary T2 signal abnormality, and excluding this cause is critical during imaging evaluation. In cases of extrinsic compression, the cause of abnormality is known and does not pose a diagnostic dilemma. Therefore, this review focuses on intrinsic spinal cord signal abnormality that occurs in the absence of an extrinsic compressive lesion. This article provides a practical approach to diagnosing some of the more common diseases that manifest as an intrinsic cord signal abnormality. It is important to start by excluding artifact or extrinsic compression as a cause of cord signal abnormality. Next, a combination of clinical evaluation results, time of onset, whether acute versus non-acute, cord expansion, and pattern of T2 signal abnormality helps the radiologist arrive at a more specific diagnosis, or at least narrow the differential diagnosis. Ancillary findings such as additional clinical workup results, extraspinal manifestations, and features on other MR images are appropriate for inclusion. Quality control is the first step in image interpretation. The most deceptive of these artifacts is Gibbs or truncation artifact, which can appear as alternating lines of low and high signal intensity extending along the long axis of the spinal cord, which can mimic a cord signal abnormality or a syrinx. This pattern is caused by the high contrast interface of CSF with the spinal cord and can be minimized by increasing the number of phase encoding steps, switching the frequency or phase encoding directions, or decreasing the field of view. Other artifacts to be aware of include respiratory motion, vascular pulsation, CSF pulsation, and magnetic field inhomogeneity or susceptibility artifact related to surgical implants. Once a true or non-artifactual spinal cord signal abnormality is identified, it is important to evaluate for the presence of an extrinsic compressive cause. Common extrinsic compressive causes include discogenic myelopathy, ligamentous thickening, vertebral body compression fracture with retropulsion, traumatic facet dislocation, and malignancy or infection of the surrounding spinal column. Usually, cord signal alteration is seen focally at or adjacent to the causative feature. However, long segment cord signal abnormality has also been associated with spondylitic change and may mimic inflammatory or neoplastic causes. While some of these causes may manifest in a non-acute setting, localized cord signal alteration in a patient with acute myelopathic symptoms should be considered to be acute edema until proven otherwise, and may necessitate emergent surgical intervention. Once artifacts and extrinsic compression are excluded, the remaining cord signal alterations can be considered intrinsic to the spinal cord. At this point, it is essential to know whether the symptom onset is acute or non-acute, as this will strongly influence the differential diagnosis. If the symptom onset is acute, categories of causes to be considered are demyelination, ischemia, and infection, of which demyelination is the most common. Let's discuss demyelinating disease, which represents a heterogeneous group of diseases with variable clinical presentation and imaging features. These include multiple sclerosis, acute disseminated encephalomyelitis or ADEM, neuromyelitis optica spectrum disorder, MOG antibody-associated disease, and idiopathic transverse myelitis. MS is by far the most common demyelinating disease, with a higher incidence in females and in populations farther from the equator. The spinal cord is affected in more than 90% of patients with clinically definite MS, and up to 20% of patients will have only spinal cord manifestations. MS in the spinal cord commonly affects the cervical region. Lesions are typically short, less than 1.5 vertebral body segments, in craniocaudal extent, peripheral, and wedge-shaped or round, and affect less than half of the cross-sectional area of the cord. There is involvement of both the gray and white matter in the brain and spinal cord. However, gray matter involvement is more evident in the spinal cord than in the brain. In acute or active disease, the lesions can demonstrate contrast enhancement from transient blood-spinal cord barrier breakdown or cord swelling. In chronic and long-standing or progressive disease, there can be spinal cord atrophy, which is thought to represent axonal loss. Many patients with MS have intracranial manifestations, so it is essential to evaluate for concomitant juxtacortical, periventricular, or infratentorial brain lesions. ADEM typically manifests as an acute monophasic illness after viral infection or vaccination, predominantly occurring in the pediatric population. On spinal MRI, lesions of ADEM may be indistinguishable from those of MS, with some potential differences. ADEM lesions are found more commonly in the thoracic cord, are usually poorly marginated, owing to adjacent edema, and are larger in cross-sectional area and longer. MRI of the brain, as well as the spinal cord, is essential and may further help distinguish ADEM from MS. Intracranial findings may mimic MS, but certain features help confirm the diagnosis of ADEM, such as the presence of larger lesions in the subcortical white matter, involvement of the basal ganglia, thalami, and brainstem, and relative sparing of the periventricular region. NMO is a demyelinating disease that predominantly affects the optic nerves and spinal cord, which occurs due to autoantibodies to the aquaporin 4 protein. The overall prognosis is worse, and the physical manifestations are more severe in patients with NMO than in patients with MS. The mainstay therapies for MS have been reported to be ineffective against or even exacerbate the underlying disease in patients with NMO, so it is critical to differentiate between the two diseases. At imaging, NMO lesions in the spinal cord are usually longer in craniocaudal extent than those in MS, greater than 1.5 vertebral body lengths, and involve the central gray matter of the cord, sometimes seen as longitudinally extensive spinal cord lesions. They frequently extend upward into the medulla. These bright spotty lesions, which are focal internal areas of T2 hyperintensity that are at least as bright as CSF with corresponding low T1 signal, have recently been shown to be highly specific for NMO and are seen in about one-half of patients. Like MS, enhancement and cord expansion can be seen in the acute setting. Spinal cord infarction is a rare cause of acute myelopathy. Spinal cord ischemia can be arterial or venous. The arterial supply to the spinal cord arises from multiple radiculomedullary arteries, which ultimately form the anterior and posterior spinal arteries. The large anterior spinal artery perfuses the anterior 2/3 of the spinal cord, and the posterior spinal arteries supply the posterior 1/3 of the spinal cord. Acute arterial compromise is often associated with plaque-related thrombosis or emboli. Other causes include occlusion related to aortic or cardiac interventions, trauma, systemic arteriopathy, or rarely fibrocartilaginous embolization. Classically, anterior spinal artery infarct produces T2 hyperintensity in the anterior horns and surrounding white matter, forming the owl's eye sign. Posterior spinal artery infarct produces T2 hyperintensity that is limited to the dorsal columns and posterior horns. Restricted diffusion at diffusion-weighted imaging can improve diagnostic certainty when cord infarct is suspected. In the subacute setting, there may be enhancement and hemorrhagic conversion. Another helpful imaging feature is the presence of concomitant vertebral body infarction due to common vasculature shared by the spinal cord and vertebral body. Frank venous spinal cord infarction is uncommon, although edema from venous congestion is common. Spinal dural arteriovenous fistula can cause increased venous pressure and has a subtle but characteristic appearance at MRI and usually manifests as poorly defined T2 hyperintensity and cord enlargement, which represent spinal cord edema. The dilated perimedullary vessels manifest as multiple serpentine flow voids along the surface of the spinal cord. Acute infectious myelopathy can be caused by viral, bacterial, and fungal pathogens. MRI demonstrates diffuse, typically non-expansile T2 hyperintensity, with or without signal alterations on brain MRI. These findings make it essentially indistinguishable from demyelinating conditions, and differentiation is more likely to be achieved after CSF sampling and laboratory tests. Intramedullary spinal cord abscess is a more serious, although rare, diagnosis and is characterized by ring enhancement and central diffusion restriction, which develops approximately 1 week after an acute infection. Let's move on to non-acute causes of intrinsic T2 signal abnormality. These include neoplastic, metabolic, neurodegenerative, and inflammatory or immune-mediated disease. In the non-acute setting, intrinsic signal alteration with associated focal expansion of the cord suggests a neoplastic process. In addition to cord expansion, additional features often seen in intramedullary neoplasm include enhancement, hemorrhage, and associated cystic changes. It is important to be aware that non-neoplastic causes such as demyelinating disease can also cause cord expansion. Let's hit the high points on the 3 most common intramedullary spinal tumors. Astrocytoma, the most common glial tumor in the pediatric population, is an infiltrative glial tumor often involving multiple vertebral body levels of the spinal cord. Owing to their infiltrative pattern of growth, they are typically poorly defined lesions with patchy enhancement and a large amount of peritumoral edema. They are associated with NF1. Ependymoma is the most common glial tumor in adults and is often seen in the cervical spinal cord. Unlike astrocytoma, it is a sharply defined encapsulated tumor and is associated with NF2. Ependymoma is usually centrally located, enhances avidly, and commonly demonstrates peritumoral cystic change and hemorrhage. About 25% of cases demonstrate the hemosiderin cap sign, characterized by a rim of T2 hypointensity at one or both poles of the tumor. Hemangioblastoma is a well-demarcated, highly vascular non-glial tumor. It can appear similar to cerebellar hemangioblastoma, with an avidly enhancing mural nodule with or without an associated tumor cyst or syrinx formation. Classically, internal flow voids and presence of a large draining vein are seen. However, despite its high vascularity, associated hemorrhage is rare. When there are multiple lesions or additional lesions in the cerebellum, what syndrome should you be thinking about? Yep, if you said von Hippel-Lindau disease, you would be correct. Several metabolic derangements can lead to spinal cord signal alteration, including various vitamin and mineral deficiencies, mitochondrial diseases, leukodystrophies, and genetic syndromes. One of the more common is subacute combined degeneration, which can be seen in the setting of vitamin B12 deficiency, nitrous oxide or zinc toxicity, or copper deficiency. Sagittal MRI demonstrates non-expansile T2 hyperintensity, predominantly involving long segments in the posterior cervical and thoracic spinal cord without associated enhancement. Axial T2-weighted MR images demonstrate hyperintensity involving bilateral dorsal columns, classically in an inverted V configuration. Neurodegenerative diseases, such as amyotrophic lateral sclerosis, can show T2 hyperintensity involving the anterolateral columns with or without associated spinal cord atrophy. The signal abnormality may be seen to extend cephalad along the corticospinal tracts into the intracranial compartment. The three most common multisystem inflammatory and immune-mediated disorders affecting the spinal cord are lupus, Sjogren disease, and neurosarcoidosis. Manifestations of these diseases are variable and quite rare in the spinal cord. At MRI, there is usually long segment non-expansile T2 hyperintensity, which can be seen in all three entities. Variable intramedullary enhancement can be seen in any of these conditions. However, neurosarcoidosis may have distinguishing features including dorsal spinal cord predominance, leptomeningeal enhancement, and the trident sign, crescentic posterior subpial enhancement with subtle central canal enhancement. It is important to look for extraspinal manifestations of these multisystem disorders, such as cystic changes in the salivary glands associated with Sjogren disease or hilar lymphadenopathy associated with neurosarcoidosis. If a patient has a cord T2 signal abnormality within a previously irradiated field, consider radiation myelitis, which is further supported by fatty bone marrow replacement in the corresponding vertebral bodies.
Wow, that was great. I'm going to listen to that again, maybe more than once. Now let's move on to my article called Imaging of the Patient with Thoracic Outlet Syndrome. The thoracic outlet extends from the cervical spine and superior border of the mediastinum to the lateral border of the pectoralis minor muscle. The brachial plexus, subclavian vein, and subclavian artery traverse the thoracic outlet, and when compressed, can result in upper extremity symptoms. Patients with symptoms from compression of the neurovascular bundle in the thoracic outlet are described as having thoracic outlet syndrome, which is best thought of as three conditions, classified according to which structures are involved: neurogenic, which is compression of the brachial plexus, venous from compression of the subclavian vein, and arterial from compression of the subclavian artery. While the diagnosis of thoracic outlet syndrome typically rests on a careful history and physical exam, imaging can play an important role in identifying the underlying cause and supporting the diagnosis. Understanding the anatomy and compartments of the thoracic outlet is essential for accurate reporting of the location of disease. Anatomically, the thoracic outlet can be divided into three compartments. The most medial compartment, the scalene triangle, lies above and behind the clavicle. The scalene triangle is bordered by the middle scalene muscle posteriorly, the anterior scalene anteriorly, and the first rib inferiorly. The scalene triangle contains only the subclavian artery and brachial plexus, as the subclavian vein lies anterior to the anterior scalene muscle. It's thus outside that triangle. Moving laterally, the costoclavicular space is bordered by the subclavius muscle anteriorly, the clavicle superiorly, and the first rib and anterior scalene muscle inferiorly and posteriorly. So picture all that in your head. The costoclavicular space contains the entire neurovascular bundle. The most lateral compartment of the thoracic outlet lies inferior to the clavicle and is known as the subcoracoid pectoralis minor space. In the pectoralis minor space, the neurovascular bundle courses between the pectoralis minor muscle tendon anteriorly and the ribs and intercostal muscles posteriorly. The anatomy of the thoracic outlet is dynamic, with abduction of the ipsilateral arm potentially resulting in narrowing of the thoracic outlet at all three spaces. This narrowing can be seen in symptomatic and asymptomatic patients and plays a role in development of neurovascular compression in these patients. The symptoms produced by compression of the components of the neurovascular bundle as it passes through the thoracic outlet are variable, and some patients may have compression of one or more of these structures. Anatomic abnormalities, such as cervical ribs, are often present in patients with thoracic outlet syndrome, but do not define it, as many patients without the syndrome may have abnormalities as well. Most patients with thoracic outlet syndrome have a history of trauma or a repetitive movement as part of a job or activity. Thus, thoracic outlet syndrome is a product of an anatomic predisposition and an exacerbating factor. Neurogenic thoracic outlet syndrome is typically thought to account for over 90% of cases, the vast majority. The most common cause is a hyperextension neck injury with a whiplash mechanism, but also falls on an outstretched arm or repetitive motion injuries from work or sport. Anatomic abnormalities, including hypertrophied scalene musculature, bone abnormalities, and fibrous bands, are also present and likely predisposed to development of neurogenic symptoms. Venous thoracic outlet syndrome is the second most common cause. The typical site of subclavian vein compression is at the level of the costoclavicular space between the first rib, subclavius muscle, and clavicle. Most patients present with spontaneous axillosubclavian thrombosis, also known as Effort thrombosis or Paget-Schroeder syndrome. The mechanism that predisposes patients to venous thoracic outlet syndrome is the anterior-based costoclavicular shears mechanism, which is present in normal individuals at the extreme of abduction. Bone anatomy is frequently normal, but there's often surrounding muscular hypertrophy due to sporting or occupational activity. These hypertrophied muscles can result in narrowing of the costoclavicular space and increased potential for repetitive damage to the vein, which can lead to wall thickening, fibrosis, and thrombosis. Arterial thoracic outlet is the rarest form, accounting for less than 3% of cases. This consists of two components: damage to the subclavian artery at the level of the first rib and distal embolic phenomena. Arterial thoracic outlet syndrome is almost always associated with underlying bone abnormalities, either a cervical rib, anomalous first rib or clavicle fracture. Chest radiography is typically performed in all patients with suspected thoracic outlet syndrome, as it can help delineate bone abnormalities. In patients with suspected vascular thoracic outlet syndrome, either angiography or cross-sectional imaging with MR or CT is performed, depending on the acuity of the presentation and potential need for immediate intervention. Diagnosis of vascular thoracic outlet syndrome with imaging studies requires the presence of findings of vascular damage. For venous, this involves identification of axillosubclavian vein thrombosis, focal fixed subclavian vein stenosis at a site of dynamic compression, or expanded collateral vessels. In the setting of arterial thoracic outlet syndrome, supportive findings include axillosubclavian arterial aneurysm or pseudoaneurysm, arterial thrombosis, focal fixed subclavian artery stenosis at a site of dynamic compression, distal emboli, or enlarged collaterals. Separate image acquisitions are often performed with the patient's arms abducted and adducted to elicit positional vascular narrowing, as this can affect surgical management by identifying the precise location of the vascular compression. It's critically important to recognize that the diagnosis of vascular thoracic outlet syndrome is not made by identifying positional changes in the vessel caliber alone. Both symptomatic and asymptomatic patients can have arterial and/or venous compression at the thoracic outlet. Venous compression is much more common, however, and occurs in over 50% of asymptomatic patients. Use of MR imaging for diagnosis of patients with neurogenic thoracic outlet syndrome has been described, but it's not yet been shown to affect surgical management. Findings that can be suggestive include edema in the brachial plexus and loss of fat surrounding the brachial plexus in abduction. Patients with suspected neurogenic thoracic outlet still often undergo plain radiography or cross-sectional imaging to evaluate for anatomic abnormalities or concurrent vascular thoracic outlet syndrome. The underlying cause of symptoms of neurogenic or vascular thoracic outlet is not always compression by bone or soft tissue structures. This should remain a diagnosis of exclusion. Superior sulcus tumors, which are a prime concern in older patients with a smoking history, can invade the thoracic outlet and produce these symptoms. These can be identified at chest radiography, CT, or MR. Primary conditions affecting the vasculature can also produce similar symptoms. A large vessel vasculitis like Takayasu arteritis can manifest as an intermittent arm or hand pain and simulate embolic phenomenon from thoracic outlet. At imaging studies, Takayasu arteritis will typically manifest as areas of vascular wall thickening with regions of vascular stenosis or dilation. Finally, patients with severe atherosclerotic disease can have symptoms of upper extremity weakness or embolic phenomenon that also overlap with those of thoracic outlet syndrome. The key distinguishing factors in these cases are to determine whether the occlusion or plaque is not at the thoracic outlet and is not directly associated with vascular compression. It's incumbent on the radiologist to identify these alternative explanations for symptoms, as they may not be suspected clinically. Conventional radiography should be performed on all patients with suspected thoracic outlet syndrome and serves as a low-cost means of identifying a bone anatomic abnormality. Even if a patient is scheduled to undergo MRI, it's still indicated as cervical ribs and other bone abnormalities could be missed on MR. In addition, conventional radiography allows evaluation of other causes, including an underlying tumor. The major bone abnormalities that are relevant to thoracic outlet syndrome can be detected on plain radiographs, and these include cervical ribs, elongated C7 transverse process, anomalous first rib, and abnormal first rib or clavicle. Cervical ribs occur in up to 6% of people. Complete cervical ribs account for 30%. These attach to the normal first rib by fusion or by forming a joint. The more common incomplete cervical ribs can be of varying length, but usually have a thick ligament extending from the tip to the first rib. An elongated C7 transverse process is defined as extending laterally beyond the transverse process of T1. Elongated C7 transverse processes are more common than cervical ribs. These occur in up to 25% of people. Similar to incomplete cervical ribs, an elongated C7 transverse process can be a causative factor due to a ligamentous band extending from its apex to the first rib. This was a lot, but the radiologist plays an important role in management of these patients with thoracic outlet syndrome. It's still largely a diagnosis of exclusion, and imaging exams are routinely used to define anatomic abnormalities and determine if findings suggestive of vascular compromise are present. All right, long podcast this week. There's so much good information we want to share. Take a look at these articles on the website because you have to see the images. And watch for more bonus cases on Twitter. Join in and learn with us. Thanks for listening. We'll be back in 2 weeks with more summaries.